Okay, hello everybody, and thank you for coming and being with us with our webinar, the third one of the International Society of Recurrent Pregnancy Loss, the ISRPL. I'm really excited that this concept and project became very popular and very successful. And today specifically, I'm more excited because we are going to have my dear friend, Professor Ali Domar, who is the Chief Compassion Officer at Inception Fertility from Harvard University School of Medicine. Professor Ali is going to speak about psychological aspects of recurrent pregnancy loss. I would like very much to introduce her more in details. Before that, I want to mention to all of you about the 7th World Congress on Recurrent Pregnancy Loss, the WCRPL. This is going to held in Singapore between the 16th to the 19th of January 2025. I really recommend all of you to go to the website, look at what's going to happen. I think today we have already the scientific program, and I am really expecting to see you there. And according to to our experience, it's going to be very successful. So please also join us to this Congress. I want to thank very much Abbott for supporting this webinar project. We all know that the relationship and working together between industry and doctors, physicians is really very important to progress, to improve our knowledge. So today we are going to have Professor Ali Domar. As I said, Ali is a PhD. She's a health psychologist who focus on the application of mind-body medicine to women's health issues. Her research focuses on relationship between stress and infertility, with a focus on the impact of cognitive behavioral intervention, as well as access to care and patients' retention. She is also a practicing psychologist and does individual, couples, and group therapy. Professor Ali Domar is the Chief Compassion Officer at Inception Fertility, the Director of the Inception Research Institute, a Senior Staff Psychologist in the Department of Obstetrics and Gynecology at Beth Israel Deaconess Medical Center, an Associated Professor of Obstetrics, Gynecology, and Reproductive Biology, part-time at Harvard Medical School. She is a past chair of the Mental Health Professional Group of ASRM. She has published dozens of studies in peer-reviewed medical and psychological journals on infertility, menopause, PMS, gynecological cancers, insomnia, pregnancy loss, and preoperative surgical anxiety. Professor Domar is on the board for Parents Magazine and served 10 years on the board of Resolve, the National Infertility Association. She is the narrator of the DVD Stress and Relaxation Explained and Infertility Explained. She is the author of 7 books, including Conquering Infertility, and the co-curator of the application Fertile Calm and Fertile Strong. She is an editor for a textbook, Patient-Centered Assisted Reproduction, How to Integrate Exceptional Care with Cutting-Edge Technology, from Cambridge University Press. Professor Domar also the co-host of the products Dear Infertility, Finding Calm When Trying to Trying, and an upcoming one called Calming Conceptions. Her latest book is called Finding Calm for the Expectant Mom. So we are going to hear Dr. Professor Domar now. After that, I will give a case presentation, a complex one. And for the last 15 minutes, we can have by the chat question and answers from you, the participants. Professor Domar, please, the floor is yours.
Thank you, Dr. Bashiri. Hold on, let me just get my slides up. I'm actually a whole lot more awake than I was the last time I was with him, because last time I was with him, we were at Aspire in Hong Kong. And I don't know, oh, here we go. And I was very jet lagged. Okay. So I'm obviously going to talk about the psychological aspects of recurrent pregnancy loss, which unfortunately I see a lot of patients. I have no disclosures or financial conflicts of interest with this presentation. And the objectives, I have for everybody here is to identify the most common psychological reactions to pregnancy loss, to recognize the difference psychologically between one or more losses. And then I really want to focus on how do you work with pregnancy loss patients and what action items can you take to help patients to support themselves. So I'm just going to talk a little bit first about the research on pregnancy loss in terms of psychological aspects. It's obviously, miscarriages are very common. They're probably about 23 million every year worldwide, which means 44 losses every minute. The pooled risk of miscarriage is at 15%, but it, obviously goes up with women's age. About, 10% of women have one miscarriage, between 1 and 9% have two miscarriages, and a little less than 1% have three or more miscarriages. I guess when you're in the field of REI, you feel like everybody you see has had three or more miscarriages. Obviously we know that age is a factor for miscarriage, including being very young or much older. Older male age, low or very high BMI, Black ethnicity, a history of previous miscarriages, smoking, alcohol, stress, night shifts, air pollution, and exposure to pesticides. And I'm sure within a year or two, that list is going to grow. So unfortunately, the medical community has not always been very sensitive to the psychological aspects of loss. And as recently as 22 years ago, in a review on pregnancy loss, they lumped together miscarriages with elective abortion, elective pregnancy termination in terms of psychological symptoms. And I can tell you, since I've seen a lot of patients who've had losses and some patients who've had abortions, it's very different. Although you all may think of it as being medically similar, they are not psychologically. With abortion, a woman or a couple makes the decision to terminate the pregnancy. So it's predictable. They can plan for it. They can psychologically prepare for it. With miscarriage, it's often it's spontaneous and it's often undesired. And a lot of people who've had abortions report guilt and shame. And miscarriage is associated with anxiety and depression, which I'll go into now. I unfortunately spend a lot of time, as I said, counseling women and men who've had miscarriages. And it's unlike any other grief. Our society just doesn't know how to handle miscarriage. There are no memories, no rituals. And, a lot of people are told not to tell anyone they're pregnant until they're at least 12 weeks. And so since most losses happen before 12 weeks, you have an individual or a couple who haven't told anybody they're pregnant, they have a miscarriage. And so people don't know what's going on. So, and I obviously believe that, the patient's emotional wellness and mental health are just as important as medical decisions in terms of physical and psychological recovery. So, women who experience a loss are more than twice as likely to have an episode of major depression. In history, when women with a history of depression, more than half of them experienced a recurrence of major depression. And this last study is one that I cite all the time. In a study of women who had experienced a loss, 94% reported that they were grieving more than 5 years after the loss. And I personally had a miscarriage 25 years ago. I still think about it. So I really do understand this, once one has had a miscarriage, one has experienced a death. So most women who have a loss blame themselves. So 2/3 blame themselves, 1/3 blame someone else. It could be their partner, it could be their doctor. They think about the loss every couple of days, and again, I think one thing that has not been addressed in the whole REI field is this issue of suicidal thoughts. And, in the infertility community, it ranges from 11 to 40%. In the lost community, in this one study, it averaged about 11%, and almost 2% reported a suicide attempt. So if you're seeing patients who have had infertility and or pregnancy loss, you need to be careful. And you need to ask them if they feel safe, if they've had thoughts of harming themselves, and if they have, you need to, immediately refer them to a mental health professional. Patients who've had infertility and miscarriage feel very out of control, and blaming themselves can be a coping mechanism. So, if they, stood for 2 hours at a party and then had a loss, they said, oh, okay, so if I get pregnant again, I just won't stand for 2 hours and then I will not have a loss. So they try to figure out what they did wrong so they can fix it. In general, women do report more psychological ramifications. They tend to score higher than men on all psychological variables. Younger couples report more devastation than older couples, more likely because they see miscarriage as the loss of a baby. And I think younger people just don't tend to have as many coping mechanisms that we tend to gain as we get older. So we know that now that women who've had a loss after infertility tend to be more distressed than women who've had a loss after they spontaneously get pregnant. And I won't go into all the details, but the research is relatively consistent that ART patients, especially IVF patients who've had a loss, report very, very high levels of distress. And, these are mostly the patients that I see. I'm actually seeing a patient now who does actually get pregnant through sex and then has had recurrent losses. Most of the patients that I see have gotten pregnant after infertility treatment. And then for them, it's a whole different ballgame. I mean, I think someone who's gotten pregnant after sex and has a miscarriage knows that, once they're healthy, they need to have sex and then they'll get pregnant again. Hopefully, someone with infertility who's gone through an IVF cycle and then has a loss, it's a much more complicated financially, emotionally, et cetera, et cetera. So if you look at the data on recurrent loss, the risk of depression or the number of symptoms that women report increase with the number of losses they've had. So that we know that women who've had more than one loss tend to be much more likely to be depressed than women who've had only one. I don't want to say only one loss, but one loss. And interestingly, and this goes against my clinical experience, this one small study showed that if women know the cause of their loss, it did not have a significant impact on anxiety, which is interesting because I've had patients who find out the cause and they have told me it feels helpful to know why. But this small study did not back that up. So, we know that women, as I said, who've had recurrent losses tend to be more stressed and anxious and depressed. About 8.6% reported moderate to severe symptoms of depression, which is what you'd expect. I'm actually surprised it was less than 10%, but very high stress levels were reported in almost half of them compared to less than a quarter of the trying group. A very small study looked at couples who had had at least 3 losses, and both men and women report high levels of distress. And even though the women did report, higher levels of distress, the men did experience a deep sense of loss. And this is something I have seen clinically where, the woman has had the loss, she gets most of the sort of attention. People, comfort her. And I think the male partner feels a very significant need and he has to comfort her. And so when I talk to men alone, they tell me that they are suffering terribly because after all, they also lost a baby, but they feel they have to stay strong for their partner because they're afraid if they show how much they are suffering, that the relationship will fall apart. So don't underestimate how much the partners, whether they're a male or female partner, are also suffering. They just don't get the attention. So in women and men who've had multiple losses, there's obviously a much higher level of moderate or severe depression. I mean, those are incredible p-values. And as I said, women report much higher anxiety levels, and they show, severe depression, stress, and anxiety. Again, I don't necessarily believe some of these scores for men, because again, I think men try to hide their symptomatology because they want to support their partner. So you would think that women who get pregnant and have a viable pregnancy after a loss would do really well during their pregnancy, but they don't. Pregnancy for women who've had a loss and pregnancy for women who've had multiple losses can be absolutely miserable. again, I tend to see, this is why I wrote a book on how to stay calm while you're pregnant, because again, someone who's had a loss or more than one losses, every single day, they are scared to go to the bathroom because they're terrified that they are going to see blood. They are terrified they're going to feel cramping. And going in for either blood tests to look at their beta or prenatal ultrasounds is agony. And so, I think when you see a patient who is pregnant after having had a miscarriage, you need to be very, very sensitive to their psychological state. They feel incredibly anxious. They feel very, very vulnerable. And a lot of women who've had multiple losses actually dread getting pregnant again. And I know that sounds ironic, but that's how they feel. So what you often see in women who've had recurrent losses is they form less of an attachment to the fetus. And so, this tends to get better. So, most losses are in the first trimester. And so most women who've had losses report their highest level of anxiety during the first trimester. But they tend to get anxious they're anxious during the pregnancy. The pregnancy anxiety does go down once they go past the date of their last loss. So if a woman's last loss was at 11 weeks, after about 12 weeks, they start to feel a little more confident in terms of the pregnancy. So in a study of almost 200 women who had had a baby, and so this was at their child's 1-year checkup. So half the women who had experienced a loss reported, very, very high levels of depression, anxiety, substance abuse, dependence. And this study found that the number of prior losses, and again, this is on women who've had a baby, is a very robust predictor of anxiety in the postpartum year. And so what this is really saying is if a woman has had at least 1 or 2 losses and then has a viable pregnancy, she's much more likely to have postpartum issues. And so having a baby does not cure her from the psychological damage from previous losses. And, I think we all think that if someone's had losses and then has a baby, they should be fine. They are not fine. So how do we better support our patients? We know that women who've had 1 or more losses are anxious, they're depressed, they feel guilty, they feel isolated. So what can we do? How can, I'm a psychologist, I know what to do, but physicians, nurses, people on the medical side, you need to remember that for our patients, that first positive beta can represent a baby. And you can tell a patient that her first beta was low, or you can tell a patient that her beta is not doubling normally, but all she might hear is that she's pregnant. And, and I know this sounds nuts to people who are used to working with patients with pregnancy losses, but after that first beta, patients are often thinking about names. Some of them are now telling friends and family, and they're imagining the nursery. And in the field of REI, now that a huge number of patients are actually finding out the sex of each blastocyst because they do PGT, I've had patients name their blastocyst. So I recently had a patient who had a male blastocyst transferred. They named it Henry. And for 2 weeks, they talked about Henry. And then she had a negative beta. And in fact, for her, she probably then suffered very, very similarly to someone who's had a miscarriage. If they already have a child, they're already thinking about the age difference, they're imagining the family. So we might not feel a little bit comfortable about a pregnancy until a prenatal ultrasound is normal, but for our patients, it can happen as soon as they find out they're pregnant. So it's important to communicate with patients in a really warm and supportive manner. You want to be really careful about language. Anxious patients, the study years ago showed that if a patient is anxious, she will not retain 93% of the information that you provide. So it's really important that anything that's important for your patient to know, you have to make sure it's in writing. And you also have to be careful about your language because, for example, if they come in for a prenatal ultrasound and the heart rate's below 100, they may seize on the fact that there's a heartbeat, not about your caution about the fact that the heartbeat's too low. So be very careful with your language. When you see a patient who's had a loss, ideally you want the partner to be present, either physically or via telehealth. Encourage a plan for support if it's a quote unquote bad ultrasound. and makes plan for support, even if it's a good ultrasound. You know, patients who've had losses don't know what a good ultrasound is. And, you know, explain to your team that patients may be very emotional at a prenatal ultrasound or no emotion whatsoever. As I said, patients who've had a history of miscarriage can be very guarded. In terms of the partner, I personally find it a huge red flag. I'm very worried if the patient has a partner and who's not present at any appointments. Or, you know, if you call a patient and tell the patient that, you know, their beta didn't double or their beta went down and they happen to be home, if their partner doesn't come home, if they're able to do so, that's also a big red flag. So here's some ways to communicate empathic communication. You know, say things, I am so sorry to have to share this information with you. I know this is not what you had been hoping or expecting to hear. I know this kind of news is very hard to hear. You may well come as a complete surprise or shock. Again, once a patient, especially with a first pregnancy, they don't know what the beta is supposed to do. They don't know what the prenatal ultrasound is supposed to show. And you may say to them either in person or over the phone or by telehealth, you know, you may have a lot of questions once you've absorbed this, and please call me back or, you know, come in to see me when you're ready. And again, many people should not be alone after they've received this kind of information. And so you can ask, can your partner come? Can a close friend come? Can your mom come? Can somebody come and support you? And over and over and over again, you need to say to the patient, there is nothing you did or didn't do which caused this. There's no reason whatsoever to blame yourself. So suggest to the patient, you know, keep a list of it. You know, you're going to go home now and it's going to hit you. And then you're going to come up with a million questions, write them all down and come back and talk to me or my team. The issue with pregnancy loss in many countries is, as I said before, women don't tell anybody they're pregnant. And so if they've had a loss, they feel very alone. But if you know someone who's had a loss, you know, you might want to think about confiding in them. And if you don't know someone who's had a loss, I can guarantee you, you know people who've had losses. People who have not had a loss may not know what to say. And I honestly, if I could have $1 for every stupid thing that a relative or friend has said to one of my patients after a loss, I'd be very wealthy. People do say insensitive or unwelcome comments. You need to warn your patients that you should expect them. And, you know, what I tell my patients is, you know, memorize a couple of what I call, you know, comeback lines that, you know, you can memorize so you're not caught off guard by what people might say to you. Again, number one thing to say to patients, this is not your fault. You did nothing wrong. We are here to support you. And if you can't think of questions now, you have lots of time to ask questions of us. Please don't feel pressured to ask questions right now. So the advice that I give to patients in terms of how they can cope with a loss is create rituals. You know, luckily now you can go on the internet and say, you know, type in rituals for pregnancy loss and 1,000 suggestions will come up. I've had a lot of patients do some really lovely things to honor that soul. I teach my patients relaxation techniques. I teach them cognitive restructuring, which is challenging automatic negative thought patterns, such as, I did something to cause this loss. You know, allow patients to express their emotions, you know, the guilt, the anger, the isolation, the jealousy. You know, again, try to, you know, encourage them to get social support. You know, I had a miscarriage in between my two daughters, and I did tell everybody, and I could not believe how many family members and friends then opened up about their own loss. So, you know, tell patients if they feel okay to sort of open up, and it's amazing how many people have had the same experience. Encourage your patients to have compassion for themselves, to nurture themselves, and tell your patients there are going to be differences between you and your partner, because the physical aspects of being pregnant and having the loss are very concrete, and for the partner, it's very abstract. You can teach your patient communication skills, but really important, they have to establish boundaries, because there are people out there, as I said, who are going to say stupid things. You know, it's God's will, or you'll get pregnant again, or whatever else. And that's not helpful for the person who's had the loss. So advice that I give patients is they need to be aware of triggers. Getting pregnant, as I said, can be a big trigger. The anxiety can be overwhelming. They may feel extremely anxious and sad on the due date of that pregnancy or the anniversary date of the loss. And it's not just at 1 year. I've had patients who called me and said, I woke up feeling really, really sad and I didn't know why. And then I realized that it was the 5-year anniversary of my loss. So subconsciously, these dates stay with us. Lots of events are going to trigger our patients. Pregnancy announcements, babies being born, seeing a pregnant woman, getting invited to a gender reveal. And what I tell my patients over and over again, it's normal to feel jealous of pregnant women. It's healthy to feel jealous of pregnant women, and they shouldn't feel guilty about it. Feelings of loneliness, because you feel like you're the only person who ever experienced this, feeling isolated, feeling angry, feeling irritable, are very, very common. So remind patients that their partner might be sad, but may show it in different ways. She may want to cry and stay home and like lie in bed with the covers over her head, while he or she might be just angry. I want to go out with friends as a distraction. And I can tell you right now that the two partners are going to have different needs. She might need hugs while he may want to go out for a run. So don't expect your partner to feel the same way or act the same way or have the same needs as you. So in terms of the clinic, teach your team phrases and coping skills with grieving patients. If a patient has had a loss, you have to be really patient with her. You need to repeat yourself. You need to make a follow-up visit. And it's very hard for a patient to process right in the middle of grief. Make sure they understand that it's normal to have anxiety, depression, grief of miscarriage, and infertility. Have resources. Have a referral for a mental health professional, have pamphlets on how to cope with a loss or losses. And also be aware of the toll these patients have on the team, on your nurses, on your front desk staff, on your ultrasound, because a lot of people who work in this field get very attached to our patients. And when a patient that we really like has had a loss or takes out their distress on us, it can affect people, your team, tremendously. So in conclusion, miscarriage, especially after fertility, is associated with very high levels of distress, including major depressive disorder and, in a very concerning way, suicidality. These negative symptoms can last for years. Most patients blame themselves. There are lots of ways that you, your nurses, and the rest of the team can support the patient and her partner using empathic communication, encouraging the use of rituals, self-care, understanding the partner might cope in a different way. And we all need to focus. And this is what I'm doing a lot of research right now. And how can we offer better patient-centered care? So thank you. I hope I didn't take too much time.
Thank you, Alice, for an excellent presentation. Let's see, perhaps Dr. Bashiri is having some issues.
Oh, yeah. I didn't realize that I was on mute. So yeah, of course. Professor Ali Domar, thank you so much for this fantastic talk and so important. This emphasizes so nicely that those patients are sick, as I'm always saying, not in the uterus only. They are all in their, psychological issues. They are not really well. And this is why we have to treat them all together in this aspect. We will come to the questions later. We have already. Just want to mention that for those of you who knows friends or for yourself who wants to go back to this talk, everything is recorded, so you can go to the link and listen to it again. And now we move to my case presentation. Lina, can you help me or?
Yes, you need to click on share screen. You should be able to share your slides now.
Share screen.
If you move your mouse, you'll see a thing at the bottom, a green square with a little arrow that
I
says
see it,
share.
but
There you go.
And then you need to go to the top to slideshow and then start at the beginning.
It's on slideshow already, no?
Then go to the left and say from the beginning.
No, it's the beginning. It's the beginning.
Okay,
Yes,
so you need to
you
get
need-
slideshow again.
You don't see it?
It's
No,
not big enough.
actually, display settings, Asher.
1 second. Oh my gosh, 1 second.
It's at the very top. It'll say slideshow.
No, right now I don't see.
All right, so there you go. Exactly. Swap presenter view.
There, perfect.
Excellent. Thank you.
Yeah? Okay. So right now we move to the case presentation. It's a complex one. And it has, of course, the relevant to the emotional issues, but we are going to focus on something else, which is the anatomical aspect of recurrent pregnancy loss. This case presentation was published very recently, and let's start. So our couple, the woman is 33 years old. She's married 5 years to a male 32 years old who is healthy. So she came to us on her 5th pregnancy. They don't have children, but this special case was that she came to us when she's already pregnant. And as I said, 4 previous pregnancy losses. In her general medical history, we know that she has congenital hypoplastic right lung. This is an autosomal recessive inheritance disease. She didn't have any symptoms. This is not a common disease. We know that her 2 brothers has the same problem. She also has a right axis deviation of the heart, no symptoms. And in addition, asthma without permanent treatment. In her surgical history, she had laparoscopy at 2018 because of right ovarian torsion. And in 2020, she had partial uterine septectomy because of bicorporeal uterus, which is a congenital uterine malformation. In her lifestyle, she's not smoking, no drinking, and she has also allergy to papaverine. She develops seizures. In environmental exposure, nothing to tell. What about her OBGYN? So basically, the most important issue is that she had bicorporeal uterus. This was diagnosed in her 1st pregnancy after the 1st pregnancy loss. And she went through partial uterine septectomy, which was considered successful. This is our pregnancy histories. You see very similar details. In 8 weeks, she had pregnancy loss without fetal heart rate, and she had 4 dilatation and curettage, 4 procedures. In the last one, she had genetic analysis of the product of conception, which revealed normal karyotype. So in her history, she had full evaluation for recurrent pregnancy loss. And this evaluation was basically according to the ESHRE guidelines 2017, 18, 22, 23. So here you see the evaluation for acquired thrombophilia, which was negative. This is the hereditary thrombophilia evaluation, which was also normal, negative results. The hormonal and metabolic evaluation was normal besides low levels of vitamin D. Immunological evaluation included RF, rheumatic factor, and ANA, which were normal. The karyotype of both the male and the female were normal, 46XX and 46XY. And as I mentioned before, in the uterine evaluation, she was found to have uterine bicorporeal uterus, which was classified as class U3C according to the ESHRE classification from 2013. And this is why she had partial uterine septectomy after the 1st pregnancy loss. Okay, so as I said, she's here in her 5th pregnancy, 7 weeks and 1 day. So in her physical examination, she was well appearing, normal heart rate, blood pressure, temperature. Basically, the complete physical examination was normal, besides the BMI that was on the level of 25, which is overweight, the beginning of overweight. The transvaginal sonography showed single gestation in utero with heart rate, and CRL was appropriate to 7 weeks and 1 day. So what do we recommend to this woman at this period of time? So let's see, it looks like very nothing. What can we help her? So first of all, we have to say it again and again, even in pregnancy, healthy lifestyle habits, physical activity is very important, twice a week, 45 minutes each time with medium intensity, which means around 120 heart rate. I'm always explaining to them that physical activity is important to reduce complication, also in the third trimester, and not only to reduce the pregnancy loss rate. Stress reduction, emotional support, intervention. We have just heard Professor Ali Domar about it, and we are insisting to do it, of course, as long as we can do it and start it before pregnancy. But once the woman is appearing in pregnancy, let's do it now. As we have just heard, they are terrified. They are so afraid from any test. You know, sometimes to do the heartbeat, it takes me 20 minutes to ask them to go to the ultrasound machine. We talked about the lifestyle, decreased caffeine consumption. We're starting vitamin D. We have to remember vitamin D here is not because the calcium and bone metabolism. It is because it is a crucial immunomodulator factor. Folic acid, we start at 400 microgram. Now, more and more, we recommend to take the high dose of 5 milligram. This woman was not getting the high dose. I'm always supporting them and recommend them to get some progesterone support. I recommend the dydrogesterone one, the oral one, which is much easier. I personally published recently a regional study from my population showing the very clear benefit. And we also published with Professor Domar a very extensive review on progesterone in pregnancy and also psychological aspect. I do recommend you to go to read this study on the Journal of Clinical Medicine. And of course, as a perinatologist, I always ask the multidisciplinary approach with pulmonologists because of the pulmonary disease that this woman having. And this was the recommendation. They do the respiratory exams. They found the FEV1 was a little bit reduced, and they recommend bronchodilators for pregnancy, as you can see here. The question that I want to raise here is, would we recommend this woman's cervical cerclage? Would we recommend a stitch to the cervix because Mullerian anomalies? Let me share with you 2 studies, and I can tell you we don't have really much. So this is a very old one. It is on more than 1,000 cervical cerclage, and around 86 were done because uterine Mullerian anomalies. Some of them got Shirotker technique, and some of them got McDonald. They also got some beta mimetic and intramuscular progesterone to support the relaxation of the uterus. So what we can see here is that the term delivery with cerclage, after cerclage, you see the 86 women with cerclage with Mullerian anomalies, 50% reach term deliveries, according to those before, 10, which is 5 times higher. And I think this information, in addition to the early abortion, which was only 4 cases, which is almost 8 times less than before cerclage, makes it very clear. And the conclusion of this study, you see also in this paper, summary of many others, and you see many of them are really old. This is what we have in the literature, more than 60% success rate in live-born with having cerclage in Mullerian anomalies. And this is the conclusion, the concept of routine prophylactic cerclage in all cases of uterine anomalies should be considered. This is the paper. I'm not saying this. I will not do it as a routine, but we have to consider this. Another study on 80 women with uterine anomalies. For 26, cerclage was done, and for 14, it was not done. And this was around 40 to 15 weeks. See what we see. Here we can see 3 different uterine anomalies. In the bicornuate one, with cerclage, almost 80% term delivery. And this is in contrast to 27 without cerclage. It's more than around 3 times higher rate of term deliveries with cerclage and bicornuate uterus. And your unicornuate uterus almost double and less percentage than bicornuate. And in our Arcuatus, it was not really statistically significant. So the conclusion was cervical cerclage is an effective procedure in bicornuate uterus for the prevention of preterm deliveries. So specifically in bicornuate, we found the effectiveness of the cerclage. But what we decided, basically myself, so as I said, very few studies on this issue. In our patient, we didn't have late pregnancy loss or preterm delivery. And this is basically the most important issue to recommend cervical cerclage. In addition, this woman with the malformed uterus, she had a procedure. We do septectomy. I assume that we really treat this malformed sick uterus. This is why, according to all this history and information, and of course, we don't have a clear indication in the literature, I decided not to perform cervical cerclage. We, of course, explained the woman. So what happened with this woman at 22 weeks? We had the late anatomy scan. We found normal fetal anatomy. However, as part of this ultrasound exam, we measured the cervical length and we found it to be very short, 3.4 millimeters. Of course, I was in shock. I was very surprised. Well, it's not that I was not expected maybe to see some abnormal findings, but I didn't like the picture. And I referred her immediately to the hospital, and we have a consultation with the gynecologist surgeon. And I was sure that in this woman, cervical cerclage, even if it is late or heroic cerclage or whatever we call it, it will be helpful. And this is what decided to put McDonald cerclage. It was performed successfully. And we, of course, do the follow-up. We later on found the uterus to be, the cervix to be like 14 millimeters. And so basically, according to the guidelines, we don't have to measure the cervix again and again. I'm not going to put another cerclage. And she got also progesterone support. The only thing that we have to look by the clinical picture and complaints. If the woman is complaining or contractions, we will have to hospitalize us and to decide if we have to remove the cerclage. So looking for the cervix again and again and the measurement is not really helpful. This was very soon after the cerclage. So later on at 27 weeks, she developed a gestational diabetes. She was well controlled by diet. We do repetitive uterine culture. It's very important for those with cerclage, with uterine malformation, and the probability of intrauterine infection, the ascending infection, because the short cervix. So we do it usually once a month, and all of them came negative, fortunately. And then we get to 36 weeks. The question was which way of delivery we were going to do and what we will recommend. Basically, there was no indication to cesarean section. However, because the obstetric history, women was, her height was 145 centimeters. In this short stature, I'm not afraid, but I don't really like to have second stage arrest of dilatation and to have this emergency cesarean section. We decided to hospitalize her, to give celestone for lung maturation, and to perform elective cesarean section. We had a consultation by the pulmonologist. As I said, we're always working as a multidisciplinary team. And we also asked the anesthesiologist because the lung disease, congenital disease, and they recommend to do spinal anesthesia. And at 37 weeks, I performed cesarean section, and we had a very healthy baby. The weight was a little bit below 25 to 2.5 kilograms. The Apgar score was normal. We also removed the cerclage when the woman was under the anesthesia. So this case again represents the multifactorial disease in pregnancy, recurrent pregnancy loss. It looks like, well, we have some, uterine problem, but we already had this septectomy. She also had high BMI, and she also had vitamin D deficiency. All of them are factors, all of them risk factors. I cannot tell which one is the cause, but we can tell that it is like a puzzle. So we recommend very much to all our patients tender loving care, healthy lifestyle. It is including the male as well as the female. We have to do full parallel screening for all the possible causes. I recommend very much to use the 3D ultrasound as the gold standard to look for uterine malformation before any painful tests like hysterosalpingography, which I'm not recommending at all. And also hysteroscopy is kind of, I don't know, let's say it needs much more facilities than 3D ultrasound, which you can do it, bedside. Cervical cerclage, according to my experience now, and also we put it in the paper we published, should be considered in patients with RPL and for malformed uterus. And this is basically specifically for bicorporeal uterus. And of course, if the decision is not to put cerclage, make sure you measure the cervix around 20 weeks, even a little bit before. We have to discuss the advantage and disadvantages of this procedure. It's not clear-cut indication, as I explained. And of course, we have to have the decision together with our couples. This is the case. Thank you so much for listening. And we now move Lina and Professor Ali Domar to the chat to see our questions. So let's see. Yeah, where are the questions? Do we have any question?
Yes, indeed. Next to the share icon, the green icon, you will see, yeah.
I don't see them. I see. I don't see.
I see them. Hold on.
It's just comments. Do you see question?
Yeah. The first one that I see is, what are your recommendations for healthcare practitioners who see the patient is very clearly struggling with depression, but aren't motivated to seek mental health support? I guess that's for me. That's a tough one.
1 minute. I don't see the question and answers, but please, Lina, can you help in that? And please, Ali, you can answer, of course.
Yeah, I mean, the problem with patients, and I was just talking to a colleague of mine yesterday, is that, if you look at the research, for example, on infertility patients, only about 22% who are offered any sort of mental health intervention, only 22% will actually do it. Lots of reasons. I think there's still this idea of shame if you need to see a mental health practitioner. And so I think a lot of it is how you phrase it. So when I talk to physicians about how they refer patients to me, as I'll say, instead of saying you need to see a psychologist or you need to see a mental health professional, you can say, I think you should have what we call a mind-body consult. So let's, the practitioner is just going to take a history and figure out how you can be healthier, both emotionally and physically. And the real key to seeing a mental health professional is for them to learn coping skills. You're not crazy. We're not saying that, there's anything wrong. We're just saying we believe that it would benefit you to be emotionally more healthy. It's a tough one. I think, my daughters are in their 20s, and it's amazing to me how much they and their generation are very open about what medications they might be taking or being in therapy. When I look at my daughter's friends, I mean, they talk to me about their therapist. I mean, people are much, much more open now than they probably were. So if you have a patient who's in her late 30s or 40s, she will probably be more resistant, but younger patients are probably getting much more open to it. So I don't think we're going to have this issue in 10 years.
Professor Domar, I just want to add, and for those who ask this, the one who asked this question is a doctor. So we are not psychologists, we are not those therapists. The only thing that I will recommend you to do is to talk about it. Give some minutes. Because if you mention like, yeah, you should go to some emotional support, let me give you some blood tests, nothing will help. Just focus on that. 10 minutes, just don't do it, or you cannot do it. Explain, tell how much it's important, give some numbers from the literature about anxiety, depression, post-trauma, and just tell them that it is helpful, if not immediately, if not to all of them, at least for some of them. Just focus on that.
I also add, if a patient I would also add that it's actually more normal to be distressed, anxious, depressed than it is to feel okay. The majority of people who have pregnancy loss feel terrible. And I think normalizing, remember I said earlier that most women who've had losses are jealous of pregnant women and they feel really guilty about it. And I say over and over again, that's entirely normal. Okay, the next
You have another question.
Can Dr. Bashiri explain why vitamin D would be beneficial?
Oh, it's for me. Yes. So first of all, I'm very important that you got the point. And let me ask to each one of you, make sure you measure the vitamin D level. I can assure you that more than 90% of them will have low levels. Make sure you look at the right units, because some laboratories using different units. And why it's important to start it before new pregnancy. It takes around 6 weeks to increase the level. And as I said, it's a very crucial immunomodulator. This is one of the factors that is responsible for the T helper 1, T helper 2 shift to sustain and to maintain pregnancy. If we have more inflammatory cytokines, pregnancy will not anti-inflammatory cytokines and inflammatory cytokines. The one who is responsible for this is vitamin D and also the dihydrogesterone. So vitamin D is important to start before new pregnancy. I hope I answered the question. And Professor Domar, you have another question?
Let me look. Whoops. I pushed the wrong button. Hold on for a second.
Q&A. You should go to Q&A.
Yep, got it. This is from someone I know. I'll leave out the compliment. How do you balance helping a patient who is so guarded that they have lost any possibility for the hope of a better outcome in another pregnancy when they have completely shut down emotionally? Yeah, that's a really good question, Dr. Bo. And I've seen a lot of patients who just can't bear the thought of another loss. I had 2 patients that I've seen at the same time, and one of them had 16 losses and the other had 17 losses, and nothing that any physician could do. And one of them had actually gone to several countries and saw every specialist in recurrent pregnancy loss. And both of them said to me, you know, I desperately want a baby, but I can't. I just cannot have another loss. And interestingly enough, you know, I counseled both of them extensively about, you know, how to prepare, blah, blah, blah. Both of them actually chose to simultaneously do gestational surrogacy and donor egg because they could not bear. And because no workup had revealed, was it an issue with the fetus or was it an issue with the uterus or with the woman's body? And so both of them used gestational surrogacy and donor egg. One of them had twins, one of them had a singleton, and they were happy. I would say if you have a patient who's had multiple losses and can't even talk about getting pregnant again, this is a really good time to refer them to a mental health professional. And I'd say, you know, because this is what we do, we talk to patients if they've shut down. And now medically, you know, if somebody knows they want a baby and they need maybe years to recover from their losses, you may want to suggest that they do an IVF cycle and freeze their eggs or freeze their embryos, just so if they, end up with, takes them 3, 4, 5 years before they were psychologically able to be pregnant again, they have, a little bit of insurance in the freezer. I've done that with a number of my patients who've had recurrent losses who can't even bear thinking about it, but they were, 36, 37, and they could not take a few years off. People who shut down are being very, very self-protective. And it's not a bad thing. Being in denial can also be self-protective, but both of them, you can be that way for a relatively short period of time. Age is not our friend when it comes to pregnancy loss. And so, so I would refer to a mental health professional and maybe suggest that they freeze their eggs or embryos. Would you agree?
Yeah, there are thank you. I want to add 2 more points according to what I see in the question, and we are running on time. First, there is a question of if we encourage to share the new pregnancy with the family. My opinion, I don't know Ali's opinion. My opinion, no. The suffer, coping with the new pregnancy. I mean, usually I recommend both couples to talk about it, to help each other. Once you share with friends and family, you will get 10 million phones a day. What happened? What's going to happen? Oh, you have headache. Go here, go there. It's really, really hard. Of course, if you need a very good friend that is part of your life, that's good. But don't make it a public issue. Once, God forbid, there will be a pregnancy loss, it's very difficult to handle it with all this environment. I think, of course, if you have professional help, it is the most important thing. If you have one person or 2, I don't know, from the family, as long as it looks for many people surrounding this, it's hard. Some couples, I recommend them to wait to 12, 13 weeks, because we know that most of the pregnancy losses will be up to this stage. And it looks like, oh, how are you old-fashioned? I'm not old at all. I know what happened with those issues when I have experience of, let's say, more than 25 years with recurrent pregnancy loss couples. What do you think, Ali?
I think it depends on your family, and I think it depends on your friends. So, if you have, a mother or a sister or a cousin or a best friend who is there for you and is supportive no matter what and knows what to say, I would definitely tell them. If you have a family,
if they are, let's say, well, I have 10 friends, I don't know who is more and who is less, I have to tell all of them.
I think in general, people have a good sense of who they can count on and who they cannot count on.
You have to meet the Israeli people.
I have been to Israel. I lived in Israel when my dad was teaching there, and I understand.
5 minutes, 50 people knows about the pregnancy.
No,
well, I
think
understand
that,
you.
again, I remember after my miscarriage, when I got pregnant again, I found that my mom and my best friend were really there for me. And so when I talk to my patients and they ask me, should I tell anybody? I'll say, well, think of who in your family or who of your friends can A, keep a secret, which is really important, and B, knows what to say. I mean, I was stunned, when I had my loss, my best friend wasn't married, had never had children, and she was amazing. So, and I've had other friends who, say really stupid things. So I think it really depends on who is in your life.
Okay, agree.
If there's nobody in your life that you can trust to support you and provide unconditional love, then don't tell anybody. Hopefully you have a partner, but be aware that the first trimester for you is very concrete and for your partner is completely abstract.
Let me ask you, please. If the woman is telling you, my mother is my best friend, but I know she's going to be in stress, she's going to call me 10 times a day to share.
Don't tell her. You have to, by the time someone is in their 20s or 30s, they know who they can trust and confide in.
Yeah. And thank you. And one more question that I see here, very great question. We have 15 minutes in the clinic for each case or couple? Is it enough? Not at all. I insist in my Soroka University Medical Center, at least 30 minutes and more. This is the minimum. And you see by the ESHRE guidelines, they explain so nicely how to build the RPL clinic. The first visit needs much, much more time. So make sure you can do it.
So
Any other question?
my advice is to have what we call an embedded mental health professional in every clinic. And so that if you only have 15 minutes to spend with the patient and the patient's expressing a lot of anxiety or depression, you know, it'd be really nice to have a psychologist or social worker right there who can take some time to talk to the patient.
Definitely.
And I can tell you from a financial point of view, they pay off because patients who get counseling are much more likely to come back. So, and if you have a mental health professional, you know, use them because we know how to talk to these patients, how to comfort them, and more importantly, to teach them coping skills. And what these patients need are coping skills.
Yeah. Yeah. Do we have, Lina, more time for other questions?
Perhaps just one more and we should be closing.
Lina?
Yes, perhaps just one more question and we should be wrapping up soon.
Okay.
We're over time.
What is the other one? I see many here. Yeah, something about psychiatric disorders and advanced gestational age in the pregnancy loss. I don't know if I have more information about this. Maybe Ali can tell. We can just say that psychiatric disorders, those that we mentioned, anxiety and depression and post-traumatic PTSD, are in general, in women at least, 25% in all gestational age pregnancy losses. But it makes sense that as long as the pregnancy loss is in higher levels, the disease may be much more deep. Do you know anything else, Ali?
Well, you know, it's sort of two different questions. How do you handle gestational? I mean, how do you handle psychiatric disorders? And then I think I understood, you know, what about women of older gestational age? I mean, the problem with women of older gestational age is time is running out for them to get pregnant again. I mean, if someone's 25 and has had a loss, they can take a few years off and mourn and grieve. If someone's 40 and has had a loss, they really can't take a whole lot of time. And if they don't feel ready to try again, as I said, I would advise them to freeze their eggs or their embryos. In terms of psychiatric disorders during pregnancy, I mean, there's a lot of concern about what medications are safe for women to take during pregnancy. And, you know, when you look at people who've been on antidepressants, for example, before pregnancy, you sort of need to look at what their history is. Because if they are somebody who has been severely depressed for years or has been hospitalized for depression or has had a suicide attempt, they need to stay on their medications during pregnancy, and it's worth taking the risk of taking the medications. But if somebody is taking medication because they just don't have enough coping skills, then I would think about having them see a mental health professional to help them taper off the meds and do, for example, cognitive behavior therapy so they don't need to take the medication during pregnancy.
Basically, just to finish with that, and basically, I recommend very much to anyone who looks to me, I'm not psychiatry, looks to me, needs help, to refer them to psychiatry. And usually I take 100% the recommendation. Of course, we discuss which drug is better and how, if we have to change. But if psychiatry is telling me, listen, the woman needs medication, I always tell the women, listen, let's take care of you first. You will feel better, and we will take care, you know, of the fetus with anatomy scan and all what we need, including the neonatologist in the delivery and so on. Okay, I think we have to close this session. Ali, thank you so much. I'm so happy that we did it, and let's hope to meet again in other webinars and meeting, and just in good circumstances.
Thank you, Asher. Thank you for inviting me.
Thank you, everybody. Thank you for all the participants. And again, make sure if you want to listen again, you can go to this link, and we have recording all this meeting, and you can listen again. Thank you, everybody. Thank you, Lina, and thank you, Ebot. Bye-bye.
Bye-bye.
Bye-bye.